So here you get a stem that shows that young lady colonoscopy is done, and that shows some of the polyps. So image is having multiple polyps, and father has died of CA colon. So the patient is worried, and that's why. What is most probable diagnosis? Familial adenosis polyposis. So this is FAP. What else you expect to find? Where else it can be found? Where else? In the colon is there, then it can be there in the stomach, or it can be in the duodenum. So there else it can be then. What else would you expect to find polyp other than colon? Then what is FAP? It is autosomal dominant. Again, disorder. There is loss of APC gene. APC is tumor suppressor gene. It is tumor suppressor gene. So this gene is lost. So long of chromosome number 5. So this leads to development of hundreds of adenomas. Hundreds of. So there is a risk of malignancy at the age of 40. So that is the main thing. Multiple polyps, loss of APC tumor suppressor gene at chromosome 5. So function of APC tumor suppressor gene, what does it causes? Generally it leads to encodes negatively an WNT pathway. So this pathway is negatively controlled by tumor suppressor gene, and it's present in colonic epithelium, degrades P-cathepsin. So it is suppressing that's multiple formation of the polyps. Can you name other inherited colon syndromes? Different colon syndromes are hereditary non-polyposis colorectal disease, hereditary non-polyposis colorectal disease, HNPCC. It's also called as Lynch syndrome, or you can get Peutz-Jeghers syndrome, or you can get Cowden's syndrome. These are the syndromes which are commonly seen. What's the classification of intestinal polyps? So non-neoplastic and neoplastic polyps. This is about polyps. So non-neoplastic, it can be hamartomas, metaplastic, or pseudopolyps in ulcerative colitis. Neoplastic can be villus, tubulovillus, or tubular, villus, and combination of two. So syndrome with hamartomas. Hamartomas are seen in PJ, Peutz-Jeghers syndrome. Then what is hamartoma? It is a hamartomatous polyps. So focal, multifocal, malformation composite haphazard arrangement. It's haphazard arrangement of different amount of tissue that are normally present in organ. So Peutz-Jeghers hemangiomas. What are the complications? It can lead to malignant transformation, obstruction, interception, malignancy, obstruction, intussusception, ulceration, electrolyte disturbances. Any of the things they can happen. So what are the increasing risk of malignant change in the polyp? So it depends upon type of polyps. If it is villus, there is 40%. And diameter, if less than 1 centimeter, it's 5%. If more than 2 centimeter, then it is 20%. So degree of dysplasia. So what are the sequence of events of transformation of adenoma? So this is called as adenoma carcinoma sequence. So how it occurs? Loss of APC, tumor suppressor gene, leading to hyperplasia, then lead to dysplasia, then lead to adenocarcinoma. So first is loss of APC, then there is KRAS activation leading to mutation and dysplasia, then there is P53, loss of three things: APC, KRAS and P53. What are proto-oncogenes? So proto-oncogenes, what are they? Normal cell gene products promote cell proliferation, and oncogenes are, these are directly causing mutation or overexpress leads to malignancy. So these are, and tumor suppressor genes, these are APC, P53. They suppress, they are the gatekeepers. Now KRAS, what does KRAS do? So that induces mutation. KRAS is the gene production marking proteins GTPase that leads to RAS MEPK pathway that signals outside the cell and instead to proliferate and differentiate. P53 is again tumor suppressor gene that causes DNA damage and leads to apoptosis, growth arrest at G1. So that leads to arrest of the growth at the G1 phase, or DNA repair, or apoptosis. Gardner syndrome, what is Gardner syndrome? So this has got additional FAP, variant of FAP having additional characters like mandibular osteomas, desmoid tumors, sebaceous cyst, and fundal polyps. So other variants of FAP, Tourette syndrome, brain tumors, glioblastoma, medulloblastoma. What are different treatment modalities for then? Subtotal colectomy. Now this colon has high risk, so subtotal colectomy, ileorectal anastomosis or pan-proctocolectomy with ideal pouch. Age is 25 years. So what is the lifestyle modifications? Lifestyle modification is dietary habits, high fiber diet. You have to need to take high fiber, decrease fat intake, stop smoking, and decrease alcohol. So to your child, what you advise, screen has to be started after 12 years. Until age of 20 years, annual colonoscopy. Endometriosis, aplastic polyp has got increased milk. So the another stem which is concerned with the 60-year male. Now how is the stem is 60-year male, rectal bleeding, external hemorrhoids, fecal immunohistochemia, positive colonoscopy biopsy reveal adenocarcinoma. So this is rectal adenocarcinoma, melanocyst coli, histological examination. How you stage the colorectal cancers? This is either by Dukes or TNM. So there are two staging system. According to this, tumor invades if the musculus propria is invaded, but it will be B1. So lymph node. So Duke staging is Wahoo A, B has got 1, 2, C has got 1, 2, and D. So for A, it's limited to mucosa, and B1 penetrates but not no muscular layer, musculus propria. Here it passes muscularis propria. And C1 So again, this is lymph node positive, no muscular, lymph node positive, muscular layer. So C lymph node, B muscular, and this is limited to mucosa. And D is distant metastasis. So muscular layer is the demarcation 1, 2, B1, B2, and C is for the lymph nodes. What is the screening age for colorectal carcinoma? Colorectal CA. At what age you need to do screening? 50 to 59. Then what is fecal immunological test? FIT. Fecal immunological test. So detects a small amount of blood in the specimen, stool specimen, and can be detected to detect globin from. It is less likely to detect globin from a bleeding and guaic based test and targets globin component of hemoglobin which degrades passes from the gut. Screening quantity and threshold for abnormal results. So it is less likely to detect globulin from upper GI bleeding, that is guaic based test. What are hemorrhoid results? Hemorrhoids are bulging cushions. How do they occur? The cushions normally function which are fixed to the proper sites and anal canal and fibromuscular ligaments called ligament stretch ligaments, and when there is constipation, loss of stress, these cushions are lost and the veins bulge. Submucosal fragment stress related to strain between anal cushions forming engorge excessive blood and resulting bleeding prolapse. What pathogenesis of thrombospine? Acute thrombosis results from sudden increased pressure, rupture of the vascular plexus leading to blood clot. What is melanosis coli? So it is generally melanosis coli. It happens pigmentation in wall of colon identified at the time of colonoscopy. It's benign and may have significant correlation with disease. So now again the questions come with coronary arteries, thrombosis, why get thrombosed? So it is atherosclerosis. It is basic of atherosclerosis. Atherosclerosis occurs when there is endothelial injury and dysfunction leading to permeability and leukocyte adhesions. Then lipoproteins are accumulated, platelets adhere there and form the accumulation of macrophages and leading to activation of platelets and form the plaques. So what are the risk factors? Non-modified, modified. So which factors can be modified are hyperlipidemia, hypertension, cigarette smoking, diabetes, inflammation. Common sites of atherosclerosis are where can the which vessels, heart, brain, renal, lower limbs, or bowel. So what is thrombus? It is a solid component of the blood and its healthy response to injury intended to prevent bleeding. So mechanism of thrombus formation: atherosclerosis is suddenly disrupted by intraplatelet hemorrhage and mechanism forces. This will expose endothelial collagen to form platelets adhere and then they activate the clotting system, formation of the clots. So what is the difference between thrombus and clot? What is the difference between two? So this is in circulating and clot is stagnant blood. There is lines, they have got lines of Zahn, no lines of Zahn, this soft. So why does myocardial infarction occurs? This is seconds of vascular obstruction, aerobic glycolysis stops. Normally there is aerobic glycolysis. So when it stops, this is stop, lead to anaerobic and ATP accumulation leads to collection of lactic acid. So lactic acid has got noxious action on the cardiac muscle. So this causes damage to the muscle, leading to infarction and loss of contractility. So this patient is about 60-year-old female. Lady has been diagnosed with CA stomach. So gastric cancer is already diagnosed. Now, so what you are going to do is gastrectomy is done, surgery is done, and patient was iatrogenic injury to spleen, so splenectomy was also done. Now pathology reports says signet ring carcinoma, signet ring cancer. Lymph nodes are positive. So this is R1, spleen involved. So how this report will be discussed? Discuss in a layman language with the patient. So you have got a cancer of stomach, not completely removed, because patient require further surgery and chemotherapy. It may come back again. So instead of recurrence, use these words. What is the plan for post-splenectomy? Spleen is removed. So what you can do in this, you have to go for a vaccine 2 weeks after surgery. So encapsulated organisms, NHS, Neisseria, meningitis, H. influenza, streptopneumonia. So for this you have to give a vaccine to prevent opportunistic polyprophylactic antibiotic, again to prevent post-immunity infections of say. So you have to give antibiotics. Then influenza vaccine yearly. 4 important risk factors. What are the different CA stomach? So what are the common risk factors? Very important is smoking is always there. So H. pylori infection, then atrophic gastritis, pernicious anemia, family history, familial adenosis polyposis, adenomas more than 2 centimeter, previous gastric surgery. These are the common risk factors. So how it develops? There is normal mucosa. It leads to gastritis, metaplasia, dysplasia, then in situ, then invasive. Commonest histological type. There are different types. Commonest is adeno. Then what are the different types of classification? WHO, Lauren, Borman. So these are the different types of classification. So WHO says different types: tubular, papillary, mucinous, mixed, poorly cohesive. So these are the different types of. So when on the surgery and 10 days after, patient develops diffuse painful swelling. So after surgery, post surgery, arm swelling. So there can be because of axillary vein thrombosis and DVT. So this is because hypercoagulability in malignancy or lymph node enlargement. So virtuous lymph node. What is paraneoplastic syndromes? What is that? There is a malignancy and there can be somewhere hormones are secreted. This is called as paramesos. In CS stomach, there is acanthosis nigrans or dermatomyositis. So these can be some of the paraneoplastic syndromes. How it lymphatic spreads? It spreads to left gastric lymph nodes. What are the routes of spreads? It can be routes of spread can be hematogenous, lymphatic, transcoelomic, or direct. Patient presented abnormal distension, shifting dullness, so it is ascites. It can be malignant ascites. Two pathological tests to confirm the ascites. Now, ascites is there. So you do tapping and cytology. Liver biopsy for METs, FNAC, supraclavicular lymph nodes. Tumor markers is CA72 for recurrence. So there is advanced disease. What is the palliative treatment? Patient is advanced disease, so that is feeding, jejunostomy, or tapping, opioids, chemotherapy. How do ascites develop? There is liver function is damaged and albumin is reduced and it increases portal hypertension. These are things. So treat the paracentesis and shunts are these are different types of ascites. What procedure specific complication of total gastrectomy? So it can be early or late. So immediately there is leak of anastomosis, pancreatitis, cholecystitis, hemorrhage, infection. So later dumping syndrome, vitamin B12 deficiency, bone diseases, recurrence of malignancy. What is dumping syndrome? Dumping, as the stomach is removed, so there is reservoir function is lost. It is again early and late. So hyperosmolar fluids are suddenly gushing inside, leads to colic abdominal pain, distension. Late is 1 to 3 hours, so that leads to hypoglycemia. What is the name of gene? So this is very namey. The name of the gene is hereditary diffuse gastric cancer. So this causes, so gene mutation inheritance is CDH1 autosomal dominant. If you have mutation in genotype, cancer may be associated with hereditary diffuse gastric cancer, colon cancer, lobular carcinoma of the breast and prostate. Breast, prostate, colon, these are also affected. Clinical criteria to select patients eligible for CDH1 mutations. So these mutations, what are the clinical criteria? Which patients screen? So now if there is family or individual. So which families you have? Case of gastric cancer family regardless of the age. So CS stomach, diffuse gastric cancer. So any diffuse gastric cancer, any age, lobular breast cancer, less than 70 years. Lobular breast cancer in the family, less than 50 years. Individual criteria, diffuse gastric cancer, less than 50 years. Diffuse gastric personal family history, first degree to cleft lip, palate, breast cancer, lobular breast cancer, signet ring, CA. So age of screening. Screening should be done 16 to 18 years. Prophylactic surgery 20 to 30 years. So what are the other than adenocarcinoma? There can be gastrointestinal stromal tumors, MALT type lymphomas, there can be neuroendocrine tumors, there can be diffuse cancer and squamous cell carcinoma. So CDH1 is a gene. It is also called E-category gene. It is a tumor suppressor gene which is deficient, and mutation in CDH may lead to types of mutation is autosomal dominant. So causes of gallstone after and cholecystitis following gastric is removed. So loss of vagal innervation of the gallbladder, because whenever you remove the movements are decreased, so vagal innervation that is lost. Why post gastrectomy pancreatitis? There can be autogenic injury. Post gastrectomy anemia is vitamin B12 deficiency. Iron deficiency anemia can be for gastric media for absorption, which is lost. Osteoporosis, steatorrhea, this can be seen. So the next term is about gastrointestinal stromal tumor, GIST. So what does it speak about? GIST, gastrointestinal stromal tumors. A type of cancer that it begins in GI tract, mainly in the stomach. It's mainly in stomach and small intestine. So arises from interstitial cells of Cajal, muscularis mucosa. How it is different from gastric carcinoma? GIST is from mesenchyme, so GIST and CA. So what is the difference? This is from mesenchyme, this is from the epithelial cells. Commonly metastasis to blood and lymph node. So this is by the lymph node. Now again the symptoms depend upon where it is located. Is abdominal discomfort, vomitings and all that, GI bleeding, dysphagia, jaundice. Patient presented with jaundice, few mixed lantern. What is jaundice? Then yellow discoloration of skin. Patient may present with jaundice because of stromal tumor. It causes compression. So ampulla fetor is compressed, may lead to increased bilirubin. So liver metastasis, hepatotoxicity. What is the function of biles? It causes emulsification of fat. How do bile cell emulsification? It has got a hydrophilic and hydrophobic, and bilirubin is conjugated to glucuronic acid. Bilirubin metabolism in small intestine, enterohepatic circulation, colonic. This is what is bilirubin form, how it is secreted, urobilinogen, enterohepatic circulation. Then there is questions about this. A mass has been found. How to diagnose? So CT endoscopy is done. What is CD117? CD117, tyrosine kinase protein. So incoated sensitive marker for gastrointestinal tumors. How immunohistochemistry? CD117 positive mast cell hemolytic melanocytes. According to symptom site, less than 2 cm, more than 2 cm, imitinib has to be started. How do you know GIST is back? Again, CD positive. Now, H. pylori is usually gram-negative microbial spiral bacteria. What is the cancer? MALT. Deficiency intrinsic factor. If B12 is deficient, then it leads to vitamin B12 deficiency, alcoholism. 74-year-old man or a woman who has undergone cholecystectomy, and during operation it is thickened and fixed to liver. So this is suspected of carcinoma of gallbladder. So what are the most common risk factor in UK? It is gallstone. So that is most common. Other factors that risk are, along with the gallbladder, age more than 70, females, obesity, smoking, porcelain gallbladder, or family history. Why does gallbladder, where it spreads? So there is a liver, already gallbladder is fixed into the bed of the liver, This is the hepatic duct. So this will spread first to the surrounding, then it goes to the lymph nodes. So here is the stomach. So it goes to the stomach, surrounding lymph nodes, porta hepatis. What is the most common type? Most common type is, again, it is glandular epithelium, so adenocarcinoma. And if suppose you have done the surgery and the wound breaks out and there is yellowish discharge, it is sepsis. Then again, the causes of sepsis infection is caused by Staph aureus. What to do is you have to open the wound, take swab for culture, allow it to drain. If that spreads inside the tissues, it can lead to necrotizing fasciitis. Most common organism in necrotizing fasciitis is Streptococcus pyogenes or Clostridium perfringens, Bacterius fragilis. So how can you suspect and diagnose necrotizing fasciitis? So cellulitis, clinically cellulitis is rapidly progressing. There is crepitus over that, and fever, tachycardia, and lab investigation raise CRP, WBC count, hemoglobin is also decreased, sodium and creatinine. So Erinic scoring system. What is the pathological changes necrotizing fasciitis? So extensive necrosis and thrombosed vessels. Tissue layers involved necrosis, the fascia and subcutaneous tissue. How to treat patient according to GIST protocol? So these are critical patient, you have to go for ABCD, surgical debridement, IV fluids, resuscitation, antibiotics, culture, sensitivity. It has to be done in ITU through the specialist, plastic surgeon, extensive debridement, plastic surgeon. So when you give broad spectrum antibiotics and patient develops diarrhea or bloody discharge, the bloody stools, then this patient develops pseudomembranous colitis or ischemic colitis. This may hospital acquired gastroenteritis. Colonoscopy will give yellowish patches, yellow patches on colonoscopy in pseudomembranous colitis. Then these are the inflammatory, you have to stop it, then see for the history of antibiotics, diarrhea, abdominal pain. To confirm the diagnosis, you have to do for ELISA test. ELISA for toxins, polymerase chain, PCR, colonoscopy. So you have to stop the antibiotic oral vancomycin. So vancomycin is his choice, 125 milligram for at least 10 days. That will, and fidoximine for the. How to detect Clostridium infection? So if there is fever more than tachycardia, hypertension, then sepsis. Male patient, smoker, then the patient is alcoholic, dysphagia, smoker, alcoholic, dysphagia, history of gastroesophageal reflux disease, and weight loss. So all this dysphagia, the word dysphagia is important. It's directing towards the esophagus. So how is the lining of the esophagus? Is non-keratinized stratified squamous epithelium. Non-keratinized stratified squamous epithelium. 1, 2, 3, 4, 5 things. Stratified squamous, non-keratinized. So most common probable diagnosis is CA esophagus, esophageal cancers. Other can be GORD, or these are the risk factors: GORD, smoking, alcohol. What is the effect of prolonged GORD? So there is a reflux. What happens? This is the esophagus and this is the lower end of the stomach. So whenever there is reflux from here, so this mucosa of this changes from stratified squamous to this mucosa, it becomes Barrett's esophagus. So these Barrett's glandular epithelium and leads to adenocarcinoma. So this is one of the things which is, so biopsy is done, endoscopic biopsy is done, and this biopsy will give grade and immunohistochemistry. So how staging is done, it is different depending upon the endoscopic ultrasound. It gives the walls, then tumor size, then thickness and depth inside the invasion and everything. So what you do is TNM staging, stage 1 to 3. So tumor how far and grading. So this staging and grading, what is their stage? And another thing is grade. So grade is pathological type. It is well differentiated, poorly differentiated, undifferentiated. Immunohistochemistry is done is cytokeratin. Cytokeratin. So what are the treatment options for? So it depends upon the stage. Esophageal cancer, if it is stage 1 limited, operable, esophagectomy. Esophagectomy plus feeding jejunostomy and anastomosis. It is also called as Ivor Lewis or Macnion plus chemotherapy. Non-operable, then debulking, feeding jejunostomy, palliative chemotherapy or stents. Pleural effusion, that can be lung metastasis. Pathological test, cytology has to be done. Thoracocentesis and all that. Patient develops suprachiasmatic lymph node, you have to take the biopsy. ECG, and if your patient severe epigastric pain, so patient having epigastric pain, rule out myocardial infarction. ECG troponin. Troponin is a complex regulatory protein, troponin C. So troponin C, I, and T sit the integral muscle contraction, cardiac muscles. The next station is 70-year-old man, colonoscopy is performed, there is rectal tumor, biopsy showing adenocarcinoma. So this is showing adenocarcinoma and suggests a poor prognosis. So what are the features suggest poor? Advanced age, poor differentiation, pathological, signet cell, adjacent structures involved, obstructing lesion, ulcerative lesion, high CEA. CEA if it is increased. What are the difference between staging and grading? Again, the staging and grading is the pathological, staging is here. Then which is common? Anorectum. If it is at the junction, this is the rectum, this is anal canal. So this is junction. There can be squamous cell carcinoma. Here is adeno. So resection has been done 1 out of 90 lymphocytes. It is N1A. Human that patient develops hepatic metastasis, the neurotype. Immunohistochemistry, tumor markers, proteins. What are tumor markers? Tumor markers are proteins found in the blood, and it can be cancer cells or hunger cells. Immunohistochemistry, antigens and antibody test. So it works with the fixation antibody and then doing it. Chemotherapy, it helps to understand the recurrence. Tyrosine kinase inhibitor, it's again, there is hypercoagulability, so virtuous triad is positive, pulmonary embolism, D-dimer and all that. What are the concerns of blood thrombus? Then station is 50-year-old, 50-year patient complaining of epigastric pain and hospitalized for pancreatitis 3 weeks back. So what is amylase and where is function? Amylase. So this is question about amylase. So this is a pancreatic enzyme, help for digestion of the starch and for digestive enzyme, pancreatic juice. So all are glycoside hydrolysis and one for the bound to starch. So what is CRP? CRP is C-reactive proteins. These are produced by the hepatocytes. So that causes a response to inflammation. Blood test in pancreatitis. So blood test in pancreatitis, acute pancreatitis, you do serum amylase, lipase, lactate dehydrogenase, and oral CRP, WBC count. Biochemical tests are electrolytes, blood glucose, calcium, and albumin levels. Patient have compression of the stomach. This can be pseudopancreatic cyst. Non-bacterial organisms that cause infection are viruses, parasites, If sudden drops mean there is bleeding, there can be what are differential treatment options to stop bleeding: surgical, non-surgical is by coiling. So how does it work? So this is coiling, stop bleeding, intervention radiology by coiling. Use real-time catheter directed and then bleeding has to be coagulation cascade.